All right, thank you. And welcome to De-Implementing Low-Value Care. This is a joint presentation from Dr. Christian Helfrich and Dr. Amy Tyler. Dr. Helfrich is a core investigator with the Seattle-Denver Center of Innovation for Veteran-Centered and Value-Driven Care and research associate professor in the Department of Health Systems and Population Health at the University of Washington School of Public Health. His research focuses on testing strategies to promote the implementation of evidence-based healthcare practices and programs and strategies to de-implement low-value care. He has a particular interest in organizational readiness to change in the context of evidence-based practices, when and why large-scale healthcare initiatives succeed or fail, and the causes of burnout in the healthcare workforce. He received his doctorate in health policy and management from the University of North Carolina at Chapel Hill and his master's in public health from the Department of Health Services at the University of Washington School of Public Health. Dr. Tyler is an associate professor of pediatrics in the section of hospital medicine in the Department of Pediatrics at the University of Colorado School of Medicine and Children's Hospital, Colorado. She serves as the director of quality improvement for the section of hospital medicine. As a health services and implementation science researcher, Dr. Tyler's research focuses on de-implementation to identify processes and strategies to stop or reduce over-testing and over-treatment that can be broadly adapted to varied contexts and disease processes to improve the delivery of guideline concordant, evidence-based care and improve patient outcomes. I'll turn it over to you.
Hey, fantastic. Thank you so much. It's a pleasure to join you all. So Amy and I are going to be talking about two things related to de-implementation. Amy, go ahead and advance. We're going to be talking about some considerations related to outcomes when we study de-implementation, and then some considerations related to health equity that we think are kind of unique with de-implementation. But to start with, let's just get us all on the same page. And I know we just got out of Wynn's session and she touched on this, but I just want to reiterate it about first, what is low value care, and then the burden. So when we talk about low value care, we're talking about diagnostic or therapeutic practices or programs that provide no demonstrable benefit, or where we do expect a benefit, but the known risks of harms outweigh those expected benefits. And when we talk about de-implementation, we're talking about stopping those practices that are not evidence-based. And specifically, we're talking about systematic efforts. And Wynn touched on this, talking about within some given system or context, we're talking about a systematic, intentional effort to end the use of a low-value practice. And the other thing that I think is important is we're talking about not when there's a new superior practice that has come out, so a new evidence-based practice that has superseded the old. We're talking about where we think the existing practice is causing more harms than good, and therefore we want to end it or alter it, whether or not there's a specific superior alternative available or not. And finally, from a sort of philosophical stance, that's already from a philosophical stance, we're talking about, we're focused on preventing patient harm, improving value, improving quality and access. There is an argument to be made for de-implementation based on cost, and certainly cost implications, cost assessments are an important part of this, but just philosophically, like what's motivating this? I think for both me and Amy, we're approaching this from a perspective where this is an imperative because of access and quality and equity, and not as a cost savings mechanism. Yeah, thanks. So in terms of the burden, I think this is really important because, in fact, the burden of low value care varies. And so why are we doing this? There's huge variation, right? So depending on the practice, depending on the setting, depending on the patient population, depending on the time frame, the amount of low value care varies. And so when we look at low value care in one setting, and again for one practice, it's not going to be the same. There's not going to be the same extent of the problem as in another setting or another patient population. But I think the important thing is every time we look at a low value practice. So for example, antibiotics for treating simple upper respiratory infection. Every time we look, we find that it is used, and on the low end, these are the 3 systematic reviews, on the low end, we tend to find a prevalence of use of around 10 to 16%. And then on the high end, you're talking about 30 to 46%. So this again is across a range of studies. So it varies widely. There's not a single level of low value care, but the important thing is that we consistently find it. There's a really great a review by Schrank et al. That's all right. I just about the cost, and I think one of the important things here is one of the nice things they did is they pulled out low value care from other sources of waste. So they're like unnecessary administrative costs, things like that. I mean, there's lots of sources of waste in healthcare, but what does low value care, something that's doing the patient no darn good, but they get anyway? And they estimated that in the US, that is somewhere between $75.7 billion to $101.2 billion. Now, there are two important things to take away from that. One is that's someone's income. So when we're talking about that's waste to us, that is suboptimal dollars spent, that's someone else's income. So that's right there. That we've got some serious stakeholders in this low value care. The second thing that's important, and this is the sub bullet there, they also estimated how much of that we could tackle, and just based on current programs that we have some evidence that are effective. So these are things like programs to optimize medication, prior authorization, shared decision-making, audit and feedback, things that we have some evidence has some efficacy in some settings. Just employing those, they estimated that somewhere between $12.8 billion and $28.6 billion could be saved just by employing what we already know how to do. And then finally, we have some evidence that medical overuse does not seem to be improving. Just in terms of these measures of overuse, we haven't seen much movement. They're not great measures, but we haven't seen much movement. At the same time, we do see movement on measures of underuse, so where patients aren't getting appropriate care. Anyway, so I'm going to talk about outcomes, considering outcomes. Then Amy's going to talk about some considerations for health equity. So in terms of assessing outcomes, so when we're talking about assessing the outcomes from de-implementation efforts, we go in and try to intentionally change something. There are three things that are, again, not totally unique, but somewhat unique with de-implementation we want to consider: unintended consequences, intervention outcome asymmetry, and then how we apply what might be termed conventional implementation outcomes. And again, this is something Wynn briefly touched on. And yeah, go ahead, so the first, unintended consequences. And Wynn touched on a number of unintended consequences. For example, so de-implementing one low value medication and inadvertently pushing a patient onto another low value medication, perhaps one that we're not tracking. And so we're not going to know, we might be increasing the use of low value care without even knowing it. That's a serious unintended consequence. There's one that I think is quite pervasive and important for de-implementation, and that's this idea of psychological reactants. When we, all of us, human beings, when we feel like our freedom is being infringed upon, when we feel like our prerogative is being abridged, we tend to respond with a mixture of anger and mistrust, or something sometimes termed counter-arguing. So mistrust and anger. And I think the important thing, well, let me just add, this is a great time to talk about psychological reactants, because I think with the COVID, with the COVID pandemic, we've seen examples of this in spades, particularly with the mask and vaccine mandates, where we've seen, real anger expressed by the part of people when they're faced with these mandates, and this issue of mistrust or counter-arguing. And there's this headline, I can't remember, I think this is always from USA Today, but about, this isn't about the mask, it's about control. That's a counter-argument that's coming up with this alternative reason why someone's doing something, a nefarious reason. And with de-implementation, that's particularly huge. Amy's going to touch on this a little bit when she talks. This is particularly huge because it's so easy for this to become an argument about cost, again, that this is just about trying to control costs. And the other thing is, anger tends to dissipate over time, but that mistrust is very pervasive, or not pervasive, but very persistent. And so there's a real danger that we end up creating problems for improvements down the road. So in terms of combating reactants, I'm sorry. So with constituencies, as I mentioned, so, there's this huge amount of waste. That's someone's income. I think that there's a real challenge with de-implementation because we have, by definition, there are constituencies that are bought into the low value practice, invested in the low value practice, obviously sometimes literally invested in the low value practice. And we've got a great example of that from the early days of the Agency for Healthcare Policy and Research, what's now AHRQ. Originally, they were developed to produce evidence-based guidelines. One of their earliest was on treatment of lower back pain. And one of the things that their guidelines recommended was against surgery, was against fusion, spinal fusion. And that met with a huge amount of resistance from surgical professional groups. And there was actually lobbying of Congress, and Congress zeroed out their budget line. That agency almost ceased to exist. And in fact, they stopped producing guidelines after that. So there can be constituencies that are literally financially invested, but even in the absence of literal financial investment, we know that there are professional people in groups are professionally invested in practices. There are political and social groups. And I think a great example of that is around cancer screening. And there are good reasons that people are passionate around promoting cancer screening. It's oftentimes this is in the context of cancers in groups of patients that have been ignored historically. And so it's important to recognize that these aren't just nefarious cost interests, but groups, there are constituencies that are really invested in some of these practices. So what can we do? One of the most informative things that we can take away from looking at this through the lens of psychological reactants is some of the history around this research. Ever since vaccinations have been introduced and used widely, there's actually been anti-vaccine protests and conspiracies from the very earliest days of smallpox. Efforts to inoculate with scraping cotton mathers and scraping smallpox pustules. There have been conspiracies, and one of the ideas, ironically, around combating vaccination has been the idea of inoculating the public and inoculating stakeholders by engaging them early. So before proposing a change, engaging with stakeholders, understanding where they're coming from, listening, including stakeholders who have financial interests, and involving them in decision making. And perhaps one of the best examples of that has been the Choosing Wisely campaign that's engaged with physician professional societies. There are problems with that. There have been many problems noted with Choosing Wisely, but there are some huge advantages, and that just is a beautiful illustration. The other thing is providing narratives, and I have this line. I don't know who I got this from. I think it was someone at KP, at Kaiser, but this idea that data tells but stories sell. And what that means is we need to be guided by the data. As scientists, we need to have our advice and decisions and conclusions rooted in valid, rigorous data collection. But when we go to explain the implications or try to share the implications, it has to be through stories. And providing narratives that actually illustrate the harms can be extremely powerful. This is not, this is not evidence by anecdote. This is when the data are valid. But when we go to share and try to make an argument, it's got to be through stories of real patients, of real providers. And then finally, revealing who bears the burden. Brownlee and Korenstein, they've written a lot on this. They've got this great article that came out in 2021. Just talking about the history of the sea change in anesthesiology in the 80s that really crystallized around patient harm, patient deaths. And that's a great example because that's a very contentious, and it was very contentious, but they do a beautiful job of illustrating how this report, reporting on those deaths crystallized, people's awareness and efforts to make a change. Intervention outcome asymmetry. So and I'm talking at the provider level. We're talking about the provider level. For an individual clinician, what's the outcome from the implementation? Typically, it's nothing. They take the patient off of the inhaler, the patient has no changing in their breathing exacerbations. They decide to forego a mammogram. The patient doesn't get breast cancer. There's the best outcome is typically nothing. And that the benefits are all hypothetical. It's some sort of prevented something, and it's divorced from the decision. It's down the road. And the provider is left with this awareness that they are unlikely to be credited in their own mind or the patient's mind for anything, any benefits that come from this, but very likely to be blamed if something happens, even if it's actually unrelated to their decision to de-implement. And there's this quote that we have from one of our de-implementation studies. This is from a primary care provider talking about inhaled corticosteroids for patients with mild to moderate COPD. But the provider said, generally, on one hand, I'd like to say that in someone who's on medication they don't need, you should try to stop it. But deep down, there's a little hesitation that if someone is doing well, why rock the boat? And that's the real issue. Yeah. So ways to counter asymmetry. We can think of this at the patient level and the provider level. One, for providers at the patient level, just establishing this expectation that changes to care are going to be made over time. And again, this sort of echoes what Lynn had been talking about, the evidence changing. It's not so much them establishing with patients that evidence changes, but just that these things are not static in terms of what's the best treatment for you, what's the best prevention plan for you. This changes over time. And this can be particularly effective with some sort of checkpoint. In 5 years, we'll revisit if this is in your best interest. And that just creating that expectation tends to deflate some of that asymmetry. And then at the provider level, I think there are a couple of things that are really powerful. One is giving the provider backup, making sure that they feel like it's not just them alone on an island. And that can be particularly powerful in the age of the electronic health record, because there are a number of possibilities for a provider to get backup from a colleague. And this can be in the form of a consultation, a live consultation, or just an endorsement of a care plan. But there are a number of ways that can happen. And then the second thing is, again, helping them understand the harms, because providers want to do right by their patients. And sometimes, again, those harms are divorced from the decision and they're way down the road, and they really are difficult to understand. Finally, with applying implementation outcomes. And again, this is something that Wynn brought up. So we've got this well-established set of proximal outcomes to implementation efforts: the acceptability of the evidence-based practice, its appropriateness, its feasibility, things that we can measure proximal to an effort to implement. And Beth Prusicek and colleagues have written a great paper about this, how to apply it to de-implementation. And for the most part, these will apply equally. Go ahead, next. Yeah, thank you. Except for there are a couple of exceptions. One, for certain unobserved low-value care, and I'm talking about a test, and a great example is like a cardiac stress test for a surgical patient who's undergoing non-cardiac surgery, routinely done. It does nothing for the patient, but is routinely done. For patients, and even in some cases for providers like a hospitalist ordering the test, these things are invisible. They're actually embedded in a routine of care that has its basis historically, but it's not something that certainly not something that the patient's invested in, and maybe not even the provider. And so asking those stakeholders very directed questions about the appropriateness of that practice can be really confusing. It doesn't mean that it's not possible to still assess those things, but it's much more effective to do that in a more open-ended way. And then go ahead and next slide. The other thing that you need to consider, and again, this is not different from implementation, but it's much more salient with the implementation. We need to consider these outcomes at sort of two levels, or in 2 points. There's the low value practice. So for example, inhaled corticosteroids for patients with mild to moderate COPD. And there's the de-implementation strategy we're trying to use to de-implement the inhaled corticosteroids. So for example, I had mentioned like getting provider backup. So let's say a specialist initiated e-consult. So the specialist is actually reaching out to provide a consult to a primary care provider through the medical record. So if we're assessing acceptability, we want to distinguish between the acceptability of inhaled corticosteroids for patients with mild to moderate COPD, both from the patient's perspective and the provider's perspective. We also want to assess the acceptability of that specialist-initiated e-consult. How acceptable is that to the patient to have some other provider they don't know reaching out and giving their provider advice about their care? And likewise for the provider, versus the acceptability of coming off the inhaler. And go ahead, yeah. Oh, and I think that's it. I'm handing it off to Amy.
All right, thank you, Christian. We're going to switch gears just a tiny bit and talk about considering equity in de-implementation. So I think we all know that disadvantaged and minority patients are at high risk of not receiving high value care or appropriate care. But are those same groups also at higher risk of receiving low value care? So in fact, some research has shown that patients from racial and ethnic minorities not only receive less high value care, but also receive less low value care than white patients. Crescent and Roneveld conducted a systematic review of studies that looked at the association between racial and ethnic patient groups and overuse of care. They included 59 unique studies, and they looked at 74 different outcomes. And what they found was that in 45% of the studies, there was no difference in overuse or in low value care across patient race. In 43%, they found that low value care was more common actually in white patients. And in 12%, they found that low value care was more common in racial and ethnic minorities. So they termed this the thermostat model, where patients get less high value care and less low value care at the same time, and those rise and fall together in tandem. However, in some cases, patients from racial and ethnic minorities appear to be at higher risk of both overuse and underuse. For example, in this analysis of Medicare data from 2006 to 2011, Spiro and colleagues looked at 11 low-value practices, such as the use of feeding tubes among patients with advanced dementia. And they found that there was a higher odds of receiving low-value care among African-American patients for 5 of the practices and among Hispanics for 6 of the practices. This was after adjusting for age, income, sex, disability status, Medicaid enrollment, and risk score. So this finding really seems to fly in the face of research that has documented gaps in appropriate care for minority patients, such as that African Americans and Hispanic patients are less likely to receive appropriate cancer screening or diabetes monitoring. So racial and ethnic minorities are indeed at higher risk of both overuse and underuse. And Spiro terms this double jeopardy. And we think about when double jeopardy is in play, that efforts that focus solely on improving health equity by improving the use of high value care, we're missing half the problem. But in fact, there's variability in how race, ethnicity, socioeconomic status affects low value care. And neither the double jeopardy nor the thermostat model prevails across all healthcare practices. We need more studies to understand under what conditions does the thermostat model prevail, and under what circumstances does the double jeopardy model prevail. And this will help hopefully inform our de-implementation efforts, but also prevent gaps in care from emerging in the future. A related but distinct equity issue related to de-implementation is the term negative subsidy. So when we think about equity issues and differences in care provided within an insured population, we know that within that insured population, all members finance the care provided through their premiums and taxes. And we also know that when we look at specifically low value preventative care or low value screening, like PSA testing for men over the age of 74, most of those tests are still covered by insurance. And then unfortunately, the use of those services that are generally low value and are often not related to an individual patient's risk of illness or a potential health benefit for that patient, but rather related to often provided more often in socioeconomically advantaged populations. So therefore, within that insured population, because all patients pay in and socioeconomically disadvantaged patients are ultimately subsidizing overuse for affluent patients. And this is what's been termed the negative subsidy. Xu and Young have found this phenomenon analyzing Medicare data. They looked at Medicare data from 2007 to 2013, and specifically at 3 low-value cancer screens that were nevertheless covered by Medicare. Mammograms for women over the age of 75 with no symptoms, preventative pap smears for women over the age of 65 or those without a cervix, and PSA testing for men over the age of 75. And they looked at whether patient income, education, and supplemental insurance were associated with these services. And what they found was that indeed higher income and having supplemental insurance, but not higher education, were associated with receipt of these services. And so because higher income and supplemental insurance were associated with receiving these low-value care services, higher socioeconomic status patients received a negative subsidy from lower socioeconomic status patients. This is a figure from that same paper, looking at the trends in the use of those low-value mammogram on the left, low-value pap smear in the middle, and low-value PSA on the right from 2007 to 2013. Each one is broken down by 4 income groups: high income, which is the darkest line, middle income, which is the red line, near poor, which is green, and poor, which is yellow. For all 3 low-value screens, the use decreased over time, which is good news. But again, across all 3, there were significant and persistent differences by socioeconomic status, with higher socioeconomic status patients using more low-value care screening. Minorities in the United States have historically experienced underuse or a lack of access to appropriate care. And as such, there's good reason for minorities to have mistrust of the healthcare system and be concerned about underuse. Indeed, these differences in how patients experience and perceive both overuse and underuse likely affect how they will receive or do receive efforts to de-implement low-value care. Crescent and colleagues looked at patients' perceptions and experiences of overuse by analyzing a phone survey of over 1,000 American adults. The main outcomes they looked at were the general perceptions of and personal experiences with both overuse and underuse, including cost-related dimensions. And what they found was that racial and ethnic minorities generally viewed both overuse and underuse as bigger problems than did whites. And then they also reported more personal experience with both. So I think it is clear that there are unique considerations related to equity, overuse, underuse, and de-implementation. Now I'd like to walk through 3 considerations for addressing equity and de-implementation. The first is to consider equity when making decisions about what to de-implement. The second is to perform subgroup analysis to understand de-implementation effects on minority and disadvantaged populations. And the final one is to partner with patients and communities on de-implementation. So first, we must consider equity when deciding what to de-implement. I think we need to ask ourselves 2 important questions. Were disadvantaged and minority populations included in the effectiveness studies? And is there sufficient evidence on outcomes for minority and disadvantaged populations to determine whether those practices should be de-implemented in those populations? And then finally, as researchers, I hope that we can focus on reducing or de-implementing overuse practices where minority and disadvantaged populations have poorer outcomes related to their overuse. We need to consider subgroup analysis in our studies to understand how de-implementation is affecting disadvantaged and minority populations. What effect does de-implementation have on equity, and are we unintentionally worsening inequity? Subgroup analysis is needed because when we look at the whole population, we may gloss over subgroups of patients whose response is quite different from the group as a whole. And even when we look at traditional 1 variable at a time subgroup analysis, we may not find differences in outcomes. So I would propose using risk profiles to group patients according to their likelihood of benefiting or having unintended consequences from our de-implementation efforts. And that might be a more powerful way of identifying inequities in both our care and our de-implementation efforts. And finally, and I think actually most important, given everything we've talked about today, we must involve patients and community partners in all phases of de-implementation. We must partner with them to identify priorities for de-implementation. What things do we need to focus on de-implementing first? How do we identify barriers faced by vulnerable populations? How do we identify de-implementation strategies that mitigate bias? And finally, how do we choose and identify outcomes that are meaningful to disadvantaged and minority groups? And now I'll let Christian summarize for us.
Yeah, and so again, just to recap, what Amy and I have been talking about are these considerations for de-implementation for two specific things. When we talk about de-implementation outcomes, this idea that we've got unintended consequences, and particularly this idea of psychological reactants that's elevated for de-implementation, an asymmetry of outcomes experienced by the provider or the agent, and then a couple of things to consider when applying implementation outcomes to de-implementation. We can do it, they're very applicable, but there's this wrinkle. And then like Amy just presented, with equity and de-implementation, there's this double jeopardy versus thermostat model, and clearly both are at play. We want to study and understand when and where and why do those arise. Amy talked about the negative subsidy. This is something that seems to be really understudied and underappreciated. And then, like Amy said, we've got historical reason for patients have different experiences of low value care and of de-implementation. That's something we need to study. And as she said, making sure to address equity as part of de-implementation, measure and look for the double jeopardy versus thermostat model. Let's understand it. Conduct these subgroup analyses. And then the most important thing, and this is important for implementation too, obviously, engaging patients and community partners and engage them right from the start. And I don't know if we've got 3 minutes left. Got time for a couple of questions. Thanks, everyone.
Thank you both so much. That was great. Does anyone have any questions?
And we're also happy to take compliments. It doesn't have to be, just flatter. We're open to flattery.
It would be well.
Hi, Bethany. This is Arthur McFarlane. I just wanted to maybe partly question, partly comment, and probably not a whole lot of flattery. Sorry, but the thing that it seems to be really itching at the back of my mind as both a DEI specialist as well as an evaluator is that de-implementation science seems to really have a communications problem. Number one, in our society, data isn't really in fashion today. And truth and some of those things seem to be really antithetical to much of what is being delivered. So it feels like de-implementation science has a huge uphill battle, because even before we had that kind of a problem, we had all of the distrust that goes along with different scientists delivering different data, delivering different messages that often conflicted with one another. And so I guess how do you propose to really battle that kind of a communication issue and problem as you go forward with doing both implementation science as well as, more importantly and more specifically and more problematically, de-implementation science?
Yeah, totally. Oh, the time's up. I'm so sorry. That's a great question, but no, that is such an important question. And I don't, the short answer is I don't have a good answer. I do think one of the things that you hit on that is really important, we're not going to data our way out of this. And again, it's like the data tells, the story sells. We've got to be anchored in the data. So it's not like data's out there, but we're not going to data our way, analyze our way to persuading people. One of the things that again, this is, talk about evidence-based, applying literature or applying findings from other literature, it's tricky. But I think in looking at vaccine hesitancy, I think that there's a rich history there, and understanding how that's evolved over time and in particular around having trusted. What we need to do to engage with people is have someone, not always the physician, or the nurse, but someone in their community actually talking with them about it, and not telling them what they got to stop doing, but just talking about their perspective. But it's got to be someone that they trust. And I totally think you're right. We've got to really go back to the drawing board. The other literature that's kind of interesting in this, I hesitate to say this because it also will sound very pejorative, but there's also some literature on cults and dealing with cult messages, and how, and the more that we, ironically, I think the more we project this intolerant message, I think we do potentially close off, and I'm thinking specifically right now about COVID. The more we project a really unwavering, we are not interested in your pseudoscience answers to COVID. I think there is a real danger that we cut those people off, those communities off in a way that we can have no further constructive conversations. And I think one of the interesting things around, some lessons from dealing with cult messaging is that continuing to have someone that the person connects with, who's just listening and continues to be receptive, but also says, I don't, your perspective, it does not match my reality, and here's what I see. Those may be things that we need to figure out if we can use systematically, if we can, I don't know if that makes sense, but use more systematically. Thanks for that answer.
Well, thank you so much. I appreciate your thoughtful answer. And so we are done with day 2 of CopperCon.
Mm-hmm.
As I mentioned earlier, we will start off tomorrow morning with Rachel Shelton talking about sustainability and equity. So certainly more opportunity to dig into some very difficult topics and focus on what's really important and making sure that we have equitable access to high quality healthcare for everyone. With that, I will say goodbye for today and see you all in the morning. And thank you again, Dr. Helfrich and Dr. Tyler.